Let's dive right into this explainer on high-yield cardiology, specifically pericardial and aortic pathologies. We're focusing entirely on next best step decision logic for Step 2 CK.
We'll kick things off by sorting out high-yield chest pain. If you've got a patient with pleuritic pain that gets better when they sit forward, you're likely looking at pericarditis. On the flip side, if they describe an abrupt, severe tearing pain radiating straight to their back, that strongly suggests an aortic dissection. Also keep this in mind. Hypotension paired with clear lungs and elevated jugular venous pressure points to obstructive shock. Think cardiac tamponade or a massive PE, rather than cardiogenic shock or pulmonary edema.
Moving on to Section 1, we'll look at acute pericarditis, specifically its etiologies and diagnoses. Acute pericarditis usually presents with that classic pleuritic chest pain and a very distinct pericardial friction rub. On an ECG, you'll see diffuse ST segment elevation along with PR segment depression. For viral or idiopathic cases, the treatment of choice is NSAIDs combined with colchicine. Now here's a quick exam trap. Uremic pericarditis actually lacks that classic ST segment elevation, and since up to half of uremic cases come with an effusion, you absolutely must rule out cardiac tamponade with an echo before you even think about initiating dialysis.
It's also crucial to differentiate between the types of post-MI pericarditis. For early peri-infarction pericarditis, if the pain is significant enough to treat, use high-dose aspirin. You want to avoid standard NSAIDs here to prevent a free wall rupture. Then you have Dressler's syndrome, which is a delayed autoimmune pericarditis hitting weeks later. The key here, avoid anticoagulation if at all possible, because you really want to prevent a hemorrhagic pericardial effusion.
Let's transition to Section 2, constriction and tamponade, focusing on the hemodynamics. Constructive pericarditis happens when a stiff fibrotic pericardium literally limits diastolic filling. This often stems from recurrent viral pericarditis, prior radiation, or in certain endemic areas, tuberculosis. Clinically, you need to watch for right heart failure signs, things like hepatic congestion, peripheral edema, and JVD with a positive Cosmol sign. Listen closely for an early diastolic pericardial knock. When you get imaging, you'll spot biatrial enlargement, but with normal ventricular wall thickness and pericardial calcification. The definitive fix for this is a surgical pericardiectomy. Cardiac tamponade is a different beast because it rapidly causes obstructive shock as fluid restricts the heart's filling. You're looking for the classic Beck triad, hypotension, JVD, and muffled heart sounds, all while the lungs stay clear. If your patient is hemodynamically unstable, your immediate next best step is an urgent ultrasound-guided pericardiocentesis. If they're stable but have recurrent effusions, a pericardial window might be the way to go. You also need to understand the mechanism behind pulsus paradoxus. This is when the systolic blood pressure drops by more than 10 millimeters of mercury during inspiration. Normally, taking a breath increases right-sided filling, but here the rigid pericardial fluid prevents outward expansion. So what happens? The interventricular septum gets pushed right into the left ventricle. This septal shift decreases left ventricular preload, which drops the stroke volume and consequently the systolic pressure.
Another major clue for a large pericardial effusion is electrical alternance on the ECG. As the heart swings back and forth within that fluid-filled sac, its electrical axis shifts with every single beat. This creates an alternating amplitude in the QRS complexes. If you see electrical alternance right alongside sinus tachycardia and symptoms of obstructive shock, tamponade should be at the very top of your differential.
All right, moving to Section 3, aortic dissection, covering both diagnosis and management. Aortic dissection typically hits with a severe tearing pain in the chest or back, especially in patients with a history of chronic hypertension or connective tissue diseases like Marfan syndrome. If you suspect a dissection or maybe the patient had blunt deceleration trauma, the initial screening test is a chest x-ray. What you're specifically hunting for is a widened mediastinum, which is often accompanied by an enlarged aortic knob and tracheal deviation. Before you even get confirmatory imaging for suspected dissection, you must start anti-impulse therapy to reduce shear stress on the aortic wall. Step 1 is an IV beta blocker like esmolol or labetalol to bring down both the heart rate and blood pressure. Step 2 is getting that pain under control with morphine. A common exam trap to avoid: do not give vasodilators like sodium nitroprusside before beta blockers. Doing that triggers reflex tachycardia, which will just worsen those shearing forces.
When it comes to definitive imaging, your choice depends entirely on the patient's hemodynamics. For stable patients, you'll go with a CT angiography of the chest with contrast to see the exact extent of the tear. But if the patient is unstable, or if they have a contrast allergy or renal failure, you need to use a bedside transesophageal echocardiogram, or TEE.
Management then comes down to the anatomy.
Type A involves the ascending aorta and carries some really severe complication risks, like acute aortic regurgitation, cardiac tamponade, and MI. Because of this, type A requires an emergency surgical repair. On the other hand, an uncomplicated type B dissection is confined to the descending aorta, and we typically manage those medically with strict blood pressure control.
Finally, Section 4, abdominal aortic aneurysms, focusing on evaluation and repair. Most AAAs are completely asymptomatic, but the rupture risk is a major concern, with active smoking being the strongest modifiable risk factor. For screening, the rule is a one-time abdominal ultrasound for men aged 65 to 70 who have any history of smoking whatsoever. Ultrasound is your go-to modality here for both that initial diagnosis and routine follow-up. Now, if a patient comes in with sudden, severe abdominal or flank pain, a pulsatile mass, or signs of limb ischemia, you have to suspect an unstable AAA. If they are hemodynamically stable, the next step is a CT scan of the abdomen. However, if they are unstable, you bypass the CT for a focused bedside abdominal ultrasound. If you see the AAA, you head straight to emergency surgical repair. For asymptomatic patients, there are strict thresholds for elective surgical repair. You recommend surgery when the aneurysm diameter reaches 5.5 centimeters or greater, if it expands rapidly by 0.5 centimeters or more within just a 6-month period, or if it's associated with peripheral artery disease. Otherwise, you manage them conservatively with smoking cessation, aspirin, statin therapy, and serial ultrasounds. Remember, missing a threshold here isn't just a lost exam point, it's a missed window to prevent a catastrophic rupture. Lock down these specific criteria and you'll be well prepared for any vascular question they throw your way.